Welcome to APA's 25th Town Hall on COVID-19. My name is Billy Zadig, Standards and Codes Administrator for APA. Allow me to review a couple of housekeeping items before we start. All attendees are in listen-only mode. We ask that you utilize the chat box for the Q&A segment of this session. While we attempt to respond to all questions submitted, should we run out of time, responses will be posted to the APA's COVID RAQ, Recently Asked Question webpage. We also remind participants to ensure their speaker volume level is set for your comfort. Our speakers are gathering us from across the continent, and as such, varying volumes will be present. Today's session will award professional continuing education credits, as well as APA credentialing points and AIA CLUs. For AIA certificates, please email billy@apa.org, and it's BILLIE, along with your AIA membership number if you have not done so in the past. Our webinar recording will be posted to the APA website later this afternoon. Additionally, you will receive a follow-up email within 72 hours providing designated links to all of our webinar recordings, presentation slides, as well as information on upcoming webinars and town halls. At this time, it's my pleasure to introduce Lander Medlin, APA's Executive Vice President, your moderator for today. Lander, take it away.
Thank you so much,
Muted.
Suzanne and the rest of the APA staff, all the work that you do to bring these town halls together. And welcome all attendees. We appreciate your engagement in these town hall meetings as we further explore the impact of COVID-19 on our facilities organizations and the education enterprise. Given the upcoming holidays, our next town hall will occur Friday, January 8, 2021, with a different target and focus on what comprises healthy, smart buildings and why you should care. As always, thank you for joining the dialogue. We'll be taking your questions early on, so please post them at any time. We're here to solve your problems and issues today, and that's what makes this a rich conversation in the special community we share. As schools finalize their planning for the spring semester, your remaining challenges need to be addressed now. That's why we chose this topic today: impact of COVID-19 and experience exchange around your remaining challenges. It's also why we chose to approach this town hall with some subject matter experts who can best advise you along with an open exchange of experiences to advance your thinking and final planning efforts. So as such, here's the format for today's town hall. I'll provide an introduction to set the past month's context, report on our latest survey results, which will also be incorporated throughout our session today, introduce someone who will speak to a premier comprehensive testing and tracing program, recognize our subject matter experts, focus on your questions throughout the session, and conclude by highlighting additional resources, closing remarks, and please don't miss it. We have a special video clip that's been prepared. In just 1 month, the U.S. added well over 4 million new cases, surpassing 14.2 million total, with infections rising in every state as the nation struggles to contain a surge on top of a surge. Furthermore, infections have exploded past single-day records for 27 consecutive days, cresting the 200,000 cases per day mark as of yesterday and showing no signs of receding. With caseloads rising, deaths are also rising. In fact, we actually had our worst month since the pandemic began. Deaths reached ominous levels, unseen up to now, exceeding 43,000 in the past month alone, totaling 277,000. Sadly, we just crested the highest number of deaths in any one day since the pandemic began, with no sure end in sight. We now have exceeded 2 victims every minute of every day. Oh. More than 100,000 people have been hospitalized, double what I reported just 1 month ago and double the peak from the first wave in the spring. Hospitals are at capacity or on the brink, and deaths could ramp up to 3,000 to 4,000 per day, or a total of 450,000 by February 2021, as the hospitals become increasingly and quickly overwhelmed. All these numbers paint a sobering picture, placing us in our worst position possible entering winter and the rest of the holiday season. Now understand, the combination could compromise our healthcare system. This final surge is looking deadly as our hardest months are ahead of us. We need a sea change in public attitudes and adherence to public health control measures if we expect to bend the curve back down to give our hospitals some relief. Several antibody and antigen treatments for COVID-19 have been approved by the FDA this past month. Most exciting, though, is the news that vaccines are coming. Let's look at the two most promising vaccines, which is Pfizer-BioNTech and Moderna, claiming 90 and 94% effectiveness, respectively, who have filed for FDA emergency use authorization and are expected to receive approval yet this month. The UK, United Kingdom, has already provided authorization for Pfizer-BioNTech. However, Pfizer's two-dose course taken 21 days apart, along with the subarctic storage requirement, makes distribution and dispensing very complex. Batches will be issued first to healthcare and frontline workers, then by descending age groups. Add pandemic fatigue, and boy, we have a recipe for further disaster. We cannot let our guard down. We must remain vigilant. We must reduce transmission by taking pandemic management seriously and heeding the simple public health measures of the 3 W's. Wear a mask, wash your hands, watch your distance, and avoid crowded settings or gatherings, especially indoors. Wearing a face mask is more important than ever, as most coronavirus cases are spread by people without symptoms. Catch that. Masks are a powerful tool and can help save tens of thousands of lives in the coming months if 95% of Americans will wear a mask. This will require commitment to a collective effort. Thankfully, our institutions have worked really hard to box in the virus through strategic testing, rapid contact tracing, supportive of quarantine, and effective isolation. Together, we have it in our power to shape what happens next. To that end, the CDC issued new guidance last week stating, wearing a mask can help protect you, not just those around you, from coronavirus transmission. Therefore, the dual benefit where cloth masks act as source control to block virus particles exhaled by the wearer and provide filtration for personal protection by blocking incoming infectious droplets from others. In several scenarios, infections and deaths fell significantly, which could also help avert future lockdowns, especially if combined with other non-pharmaceutical interventions. The second CDC recommendation concerns people who may have had a coronavirus exposure, but are asymptomatic and can quarantine for 7 days instead of 14 if they test negative, or after 10 days without a negative test. Convergence of the pandemic and the economy are further exacerbating economic devastation. New filings for jobless claims declined to 712,000 last week after a recent jump as the labor market recovery navigates a surge in virus cases. However, the fact remains that there are 20.5 million people receiving unemployment benefits. There looms the potential for millions of housing evictions, and 50 million people could go hungry as we approach December 31, 2020, and the end of the stimulus package. The Federal Reserve Chairman recently remarked it would be inappropriate to allow these programs to expire. COVID congressional relief talks did gain a little ground this past week. And despite the good news about vaccines, U.S. consumers are growing pessimistic about the economy amidst the new daily virus increases. Households are definitely feeling the financial pain. But in contrast, stocks rallied to new highs. Go figure. Now, COVID's imprint on higher education is further accelerating the financial issues that existed pre-pandemic. That's declining enrollments, diminishing resources, widening skills gap, groundbreaking technological shifts, and deteriorating facilities. Now, I mentioned during the last 2 town halls the unfortunate undergraduate enrollment drops and the College Board's published tuition and fee increases for 2021 that averaged 0.9%. That's what I said, 0.9%, the lowest since the early 1990s at both public and private nonprofit institutions. In addition, the pandemic has cost colleges and universities an estimated $120 billion. Stopgap incremental measures won't solve this situation. The coronavirus has indeed amplified the financial crisis institutions were already grappling with pre-pandemic, arguably the most painful period in the history of American higher education. That's the backdrop for finalizing our preparations for spring semester reopening. No matter what form it takes, the stakes remain high given the incredible stress on institutional budgets and the need for change to meet this new and different future. Now, we narrowed down some of our latest survey responses into this infographic you see right now. Boy, did things change from June to opening and now to your reopening decisions. Reflect on May, June stark difference. Did you know that the number that our institution said would go face-to-face was 71% of institutions? Well, that didn't happen, did it? Big, big differences, and you can see that here. But now for PPE, not a lot changed, but you still have some issues with procuring the supplies you need. In particular, gloves and these nitrile gloves and cleaning wipes and face coverings. All of these things are still things that you are searching for, and it's really getting frustrating. And please note that other percentage difference, folks put in MERV filters and things related to the HVAC situation, along with electrostatic sprayers and touchless, touchless what we call soap dispensers. So these are the reasons why that number is up, but it's still concerning that we have procurement issues. These are all located on our website already, COVID resources. And I was actually surprised that wastewater testing scored so low in terms of the people that are utilizing it. We'll hear more about that today. So as I mentioned, our approach to this town hall comprises one presentation on a testing and tracing strategy. Then we're going to move to address targeted topics from our latest survey. This will take the form of an experience exchange and engagement with a few of your colleagues who have graciously agreed to serve as subject matter experts. Now let's start with an update from the folks at Duke University on their comprehensive testing and tracing strategy. And I'm going to introduce you to Kyle Kavanaugh. He's the Vice President for Administration. You can see him on the video. Duke University and Duke University Health System, so it's a big job. Kyle leads a broad and diverse portfolio providing services to Duke's 38,000 employees and 15,000 students across the university and health system. In addition, Kavanaugh holds a faculty position with Duke's School of Medicine and teaches within the Master's in Clinical Leadership program. Prior to Duke, Kavanaugh previously held senior positions at University of Florida, the University of Texas at Austin, Rice University, and Vanderbilt University. Big deal. Kavanaugh holds 3 master's degrees in business administration from Belmont, in health promotion and exercise science from Vanderbilt, and in special education from the University of Illinois at Chicago. Well, you've been busy, Kyle. And he received his bachelor's degree in special elementary and early childhood education from Tusculum College in Greenville, Tennessee, which I told him that is where my mother went to school, and we all grew up. So it's amazing. Kavanaugh teaches, consults on occasion, is an actively engaged faculty member with the Kubo CBMI, which is the College Business Managers Institute, which was one of the first things I went to way back when, and the AAU, which is American Association of Universities HR Human Resources Institute. Kyle?
And thank you very much. And what an amazing introduction in terms of setting the stage. I was trying to think of, were there things that you didn't cover? And I didn't come up with many, but let me throw out 3 just for the group to be keeping in front of them. One is certainly the challenges that we're dealing with international students. And there is some glimmer of hope that in 21 we'll see some changes there. The other 2, for those of us that are continuing to play intercollegiate athletics, that has certainly created its own set of challenges. And then those of us that are running campus transportation systems. I have put together a number of pieces here to tell a little bit of our story for the fall. Thank you for the opportunity. I wouldn't want this to be conveyed on what anyone should do. It is simply an opportunity to share what we have done and what we're planning for as we look towards 21. Billy, I think you're going to help with slides. If you could bring up the first one and we could move right to the second one. So we're going to move through our comprehensive testing and our tracking system. This is probably the most important slide that I could share out of the deck. This is not something that we had in place going back during the summer. It has evolved over this semester. And now it really is the structure of how we're managing things looking into the fall and beyond. So we have a coordinating body that has actually been meeting every single day since January 27th, probably much like your bodies as well. One of the reasons for that is we have brick and mortar over in China. And when this started for us, this was more of an issue with our China campus than it has been here in Durham. That has changed rather substantially. The second piece that I'll talk about a little bit more is this box off to the right. We have a faculty modeling team, and we are using large amounts of data on a very regular basis that is actually helping us to build a dynamic testing system. So although we have a plan going into any given, depending on what happens during the course of that week, we can adjust. So for example, if we find that we've had a potential emerging cluster in a group of students off-site, we can actually adjust where our testing is being deployed. So that has been a very integrated approach on our whole system. I want to run through these boxes very quickly, but it's important to understand that none of this existed, right, 6 months ago, and we now have dozens, if not hundreds, of people that we've deployed to pull this off. So we did have a comprehensive testing strategy. We required students to get tested prior to coming back to Durham, both our undergraduate and graduate students. Then we did test every student upon arrival in what we call baseline or gateway testing. After that, it took us a while to ramp up our surveillance testing. So we started relatively modestly. By the end of the semester, we were in steady state doing about 16,000 tests per week in our surveillance pieces. We are very fortunate that as part of the Duke structure, we have a large health system. We have 3 hospitals and dozens of clinics, and we have very regular access to quick turnaround on symptomatic testing. And then we've set up very robust testing for our athletic programs that is tiered off of the risk status of the sport. So for example, for basketball and for football, we are testing on a daily basis all of the coaches, the trainers, and certainly the athletes. Within the surveillance area, we have a large operation in data management. We're doing this internally. It is self-administered using nasal swabs. I'll give you a drill down into site management, but this has become a large component of our overall strategy. A unique aspect of our symptom monitoring piece has been the last bullet on here that says medical follow-up. So this is an internally built symptom monitoring system for our faculty, our staff, our students. In order to get regular building access, you have to complete this symptom monitoring on a daily basis. Obviously, if you don't complete it, you're not able to get into your work area or complete your job. If you do report a symptom in the morning, there is actually a medical follow-up. So a lot of symptom apps that are out there will be what I would label as passive. So somebody indicates they have a symptom, it's telling them not to come to work, but then it puts the onus on that individual to call and tap into the system. What happens in our symptom monitoring app, if someone does actually identify that they've had a symptom or exposure, there's a medical follow-up that's reaching out to them. That has been one of the ways we've kept people either off the campus or kept them contained. Really fortunate that we had really no significant supply chain issues as it relates to PPE or masks. We currently are sitting on a large volume of those ready for deployment in about 3 weeks as we get ready for the spring piece. A large operation in terms of isolation and quarantine. Certainly one of the mistakes I made in getting ready for our fall semester is we did great anticipation of what we would need for isolation. I did not do a very good job of actually identify what would be our need for quarantine. So for those students that we actually did isolate on the campus, we probably needed 4 to 5 times that amount for quarantine space. So that's an adjustment going into the spring that we've had to make. We also have had an entire team of people behind the isolation and quarantine activity to support those individuals that actually go into isolation and quarantine. Again, fortunate that we have a robust medical management system. We have a large employee and occupational health unit. We have a student health unit, and then we have reliance on primary care and infectious disease. Contact tracing has been really a significant component of what we've experienced, and if we had any level of success, it probably is a combination of the student behaviors themselves and then what we were doing with contact tracing. So any individual that's positive, we have very fast contact tracing, and we were very aggressive in putting any exposures into quarantine, both graduate and undergraduate. Every one of our individual schools, we have 10 schools, and every one of our administrative units, whether that's development, athletics, finance, technology, has an individual that we meet with on a weekly basis that we refer to as our return to workplace coordinators. They have been the main interface with our facilities operation people. We have a robust COVID hotline, and then of course, daily interface with our county health department. Okay, Billy. If we look at this next slide, this is an indication of where we started. This grew to 15 sites plus a mobile site. So we had 15 individual sites spread across each of our campuses, and these were operational from about 8 in the morning till about 6 in the evening. We actually had these staffed, as I mentioned earlier, that we were using a self-administered nasal swab. All of the technology was built here. So if I could describe it very quickly, you walk in, you take your iPhone that has the symptom app on it, you actually link it to the barcode on a vial, open the vial up, take a swab, swab your nose, put it in the vial, put it in a bag, you're done. The whole transaction is about 3.5 to 4 minutes. Steady state, again, we got up to about 16,000 per week for each week. We are looking at, we may be in a double capacity there based on the number of students we're bringing back starting in January. By the way, that's 34 days, not that I'm counting on those. Okay, Billy. If we look at what our data look like going in for the fall semester, we started on August 2nd, going up through prior to the start of our exit testing. We had just shy of about 180,000 tests. Of those 241, the students split fairly evenly between graduate and undergraduate, and then also those that were on campus, off campus. We did not have a single attribution to classroom transmission. We had no transmission in the residential dorms. Most of this, when you actually get to attribution, ended up being aligned with some level of student travel. Smaller groups, not the large parties that we've heard about, but actually groups of 2 to 4, and almost uniformly food was involved. So people taking their masks down, even having a dinner with each other, and boom, we have a transmission. Okay? Billy, we can go to the next one. One of the real key issues is we've been very aggressive in requiring. We have had this in our health system for years. This is the first year that we made as a condition of employment for everyone to be required to get influenza vaccination, both our employees and our students. We're actually now over 40,000 employees. We're about 9,000 that have been administered. Coming in our gateway testing here in January, that will be one of the checkpoints for students. They will be required to have this prior to enrolling, okay? I mentioned earlier our faculty data modeling group. This is a group that has been just a godsend for me personally in terms of using all of the information that we're pulling together on a daily basis and adjusting what we're doing. So we're certainly looking at our testing information, but we're also looking at local information in the counties that we reside in or touch that are around us. We also have a data sharing effort that's going on with the Ivy Plus schools. So we're actually starting to share some school data to see what learnings we can have out of that. And that's actually helping us then make decisions about allocation of resources, what mitigation strategies that we need to adjust, and then what we need to do in terms of our overaction with our community, okay? We were fortunate that the Centers for Disease Control asked us to write up what we were doing. That went through a peer review process, and that was actually published back in the middle of November. For folks that want a little bit more of the science behind exactly what our pooled strategy was and how we use that, I'd refer you to this piece. In essence, what we did do is instead of doing individual tests, we use pools of 5. So it really cut down on utilization of reagents, for example. If we have a positive in that pool, we're very unique in that we have a vaccine institute here. We could take that pool of 5, deconvolute it, meaning break it into individual samples of 5, and then run those through a clinical test. That worked exceedingly well for us to hit large numbers of people and then to have very fast turnaround time. Okay, Billy? As I mentioned earlier, we are 34-ish days away. We went through the start of this fall semester. Then we did exit testing going into the Thanksgiving holiday. We still have a small residual number of our graduate students that are here with us now, working in laboratories, postdocs, and faculty. So we're still testing about 3,000 individuals each of these weeks leading up until the end of December. Starting on January 4th, we will be bringing back all of our health-related students, so our School of Medicine, School of Nursing, our PAs, also our School of Business. One of the things that took us a while in the fall was to ramp up our surveillance testing. Now that we have some of the kinks that will work out, is on the 4th, we start with some of our gateway testing, but on the 11th, we'll start right up with our surveillance testing for those individuals that went through the gateway testing in the preceding week. So they will be bookend against each other. So we'll require all of our undergraduates, all of our graduates to go through gateway testing, and then we'll move them into our frequency of surveillance testing. It will depend on a number of risk factors as to the frequency of surveillance. So we got all of our undergraduates, both on and off, into a 2 times per week cycle. It depended on what happened. So if we had, for example, a fraternity that wasn't doing exactly what we would like them to do, they may move into a more frequent testing regime. So a lot depended on what occurred through there. We'll also be using this data, and given what Lander indicated is going around the country, we are anticipating much higher numbers of positivity going into the January timeframe. So we have significantly increased the amount of contact tracers that we have, the amount of inventory that we'll have for isolation and quarantine as well. Okay. Couple things here. These are all the components that we had in place going into the fall semester. Just highlight a couple things here that have been critical for us. We've worked very closely with our leadership across our facilities management group. We've worked on our ability to make our own hand sanitizers. One of the things that's actually been more challenging than the sanitizer itself has actually been the containers that they sit in. So we have now worked with one of our labs in actually producing those as well. So that has helped from a supply chain standpoint. Mentioned earlier that face coverings and masks, we will be providing those again to all of our faculty, our staff, and our students. We will enhance our integrated testing strategy. Really, the only couple of differences here to mention, Lander mentioned some of the changes that the CDC just put in place. We do currently test any of our students that we have in quarantine, but we are now certainly going to move from the 14 to the 10-day, and we're under discussion about whether we would go ahead and move all the way to that 7-day with a negative test to be able to leave quarantine at that point in time. We're really fortunate that our relationship with our county public health unit has been terrific. We share, obviously, as required, all of our positives, but we share a fair amount of our contact tracing information with them. That has really helped in terms of taking a look geographically as what's going on and whether we need to make any adjustments. And Billy, I think I have one more after this. The last thing I would say is because we have a large health system, I'm currently co-leading a working group that we have on our plans, which are well along the way of vaccination distribution. We are anticipating that there will be an emergency use authorization for the Pfizer vaccine on the 10th, which would then position us to receive some of this in about a week and a half here. We are looking at our first wave of vaccinations possibly going out the door on December the 15th. This will be aimed predominantly at our nursing staff working with positive COVID patients, but also we have a large, on the university side, group of research underway with the virus itself. So that will be in what we refer to as our phase 1A. We are not anticipating this will have a significant play in our student population for the spring, but we are anticipating that it will have a play for some of our higher risk faculty and staff through the spring as well. We're remaining very optimistic on a number of different things. I think we have been able to demonstrate to ourselves that keeping folks safe on the campus itself, we've been able to do that. Off campus, a much more significant challenge for us. We have, because of our health system, have witnessed significant improvements in the actual treatment of COVID, and now being very optimistic on what the vaccination system can do for us as we look in the spring. Lando, let me stop there. I hope this was helpful, and if there's anything in terms of follow-up questions, I'd be happy to take any.
This was very helpful, and I know you have very little time, but I do want to comment that definitely I'm so happy that I did this, because Duke is definitely the gold standard in this area, and you've given us so many good things to think about in terms of the fact that you use large amounts of data and use that to as in an integrated way to drive testing and decision making. I love this thing of from symptom monitoring daily that you cannot access the building. Now that some other folks that I read about said did the same thing. If you don't do that, you got to make sure. Someone said in the readings that you could not enter, that you couldn't get into your IT address, that you were cut off until you responded to contact tracers, which I thought was really amazing. You're certainly following a set of rules and regs that you've put in place as a model, and I appreciated that. I also recognize that you're doing this stuff on the timeliness track, and we do have challenges out there. So one, if you just have a little bit of time, I want to make sure that we ask. Someone said, so Duke pulls samples in groups of 5 to test, but if it's positive, they can break it down and determine which one person was positive. Did we catch that right?
You caught that exactly right. This is we're incredibly fortunate with some of the researchers that we have here. This is actually building coming out of the HIV world in looking at what is referred to as pooled surveillance testing. We were actually, because of the very, very low positivity rate that we had, thinking that we may be able to move to pools of 10. If we do that, all the numbers that I indicated actually double in terms of our capacity. But just repeating it very quickly, yes, that we take, if you will, 5 individual samples. Those are pooled on a platelet, and then they are tested. If we have a positive, now we know we have a positive in the pool, we just don't know what pool it is. In the way that we do it, in some cases, you had to bring those 5 people back. We have enough of a sample that we're able to actually break those apart and then run the individual tests there. It's a much more efficient and certainly cost-saving way of doing it.
Very good. And indeed, many folks are doing the 10, and that's working. I think that I'll ask Chris after you drop off about that. So another person said, how much of this enacted strategy and plans have been supported by any federal monies? That could probably be a joke, but is this done with campus resources or subsidized by outside sources of funding? Are you seeing any of that, or is this all internally driven through Duke's resources?
We refer to it as the COVID budget black hole. And so, the exact dollar amount is still very much a moving target, but no, these are all internal resources.
Okay, that's what I thought. You provide face shields or face masks for all students. I'm correct on that, I think, for everyone, right?
That's correct.
And then someone asked, do you provide sneeze guards in the classroom?
We haven't provided sneeze guards in the classroom, but one thing I failed to mention that I wasn't smart enough to recognize is where we have put them in is each of those testing sites that actually self-administering that nasal swab, there's a high probability that people are going to sneeze when they do that. I didn't know that kind of going into this. So that's probably the primary area where we've put those.
Okay, that's really a good point. And then I do have one. Do you have a phone app? You said you do either the iPhone or an Android where you have a barcode that you're utilizing. So someone wanted to know, what phone app are you using for this? And are you using a phone app also for monitoring, the follow-up monitoring?
Yeah, it's all internally developed, so it was
Okay.
through our own IT group.
Okay, all right. And then it said it'd be great to share how many cases you had with the Duke student population and what was the total student population. I think I mentioned earlier it's like 15,000 students, right? And
Correct.
you had a positivity rate below 1 that I read.
Yeah, we had going through into Thanksgiving, before we did exit testing, we had 241 total, and of those 241 total, 152 of those were students. Of that 152, it was about half and half between undergraduates and graduates. So say, 75-ish of the undergraduates, and of the undergraduates, about half of those were on and half of those were off. So we only had about 35 to 40 on campus actual. And then if we looked at how did that happen, everyone has their own unique story, but it was the boyfriend, girlfriend that resided at another school that somebody went to visit and then came back. So we had, again, virtually very, very little transmission on the campus itself.
Okay, very good. And I think you have this relationship with the local public agency, and who's the entity that has contact with them?
It really comes through a combination of pieces. So I'm sure everybody's aware, any positive test has to be reported, certainly in North Carolina, to both the state and the county. So that is actually coming out of our laboratories in terms of that state. And then we have a physician in employee health and a physician in our student health that are the primary interfaces, along with a key leader in our infectious disease space.
Okay, very good. And I did hear you talk about vaccination. You said influenza that everyone must have before they come in, the influenza vaccination. Am I correct? Did I get that correct?
That's correct. We've been doing this for years within our health system. It's been a condition of employment. It's the first time that we've moved it to the entire university was this fall. Okay,
very good. I think that's really good to know. And you've already answered another question that was asked, and I'm going to ask for Karen, who's one of our subject matter experts. She wants to ask a question. Karen, you want to open your mic and ask Kyle before we let him go?
Yes, thank you. So Kyle, one of the things that we have found as a challenge is knowing who is on campus. So we have so many students who are taking their classes in a hybrid manner or offline altogether. And so being sure that we get all of the students who come to campus tested is a challenge. We're looking at tying into Blackboard, tying into Wi-Fi data. What do you do in order to know for sure how many students are on campus so you're testing them?
Yeah, my colleagues in the graduate student space, if they were here, they would be demonstrating pulling their hair out. Our graduate and professional students have been much more elusive than our undergraduates. So number one, even as I speak, I'm on campus now. Every one of our buildings is, in our lingo, right now in a controlled access. What that means is you can't get into the building unless your card has given you access to that. For our student population, you can't get into that building unless you've completed your symptom monitoring app and have successfully gone through testing. So if you've not gone through testing, you can't get into the building act. So it's been successful. The very first week that we had this, when we did surveillance testing, if you were scheduled to go into surveillance testing and you did not complete it, we knew you didn't complete it, and you got a love note that said, Karen, I see you didn't complete it. Your card is turned off. What that meant for the student population is you didn't eat. And so our compliance with our student population was like 99.9% by the second week. So I would say it's really building access has been the primary control mechanism.
Great. That's really great to hear. Yes, and thank you so much, Kyle. We really appreciate it. I've enjoyed this whole thing, and I'm so happy that John Noonan answered my call or plea Who's the person that does this? And obviously you are. And you look like you still have some hair. So that's a good thing. All right.
You don't see the back. You don't see the back.
Okay, we won't look back there. It's too shiny back there, huh? Okay, so thank you so much, Kyle. I appreciate it. I know you have to go to a trustees meeting, if I have that right. So let me let you go. All right.
Bye-bye. Good luck.
You. All right. Thank you so much. All right, everybody. I want now to make sure I introduce our subject matter experts and get them on screen. I've got Eleanor Nell Davidson, MD, adjunct instructor, bioethics and medical humanities, Case Western Reserve University School of Medicine. Then I have Karen, who's already on, Karen B. Donahue, Associate Vice Chancellor, SUNY Office for Capital Facilities, the State University of New York. Then I have David Handwerk, Assistant Vice Chancellor for Facilities Management, Arkansas State University. And next comes, they're in alphabetical order, David Kang, Vice Chancellor for Infrastructure and Sustainability and Chief Facilities Officer, University of Colorado Boulder. Then Chris Kopak, Associate Vice President, Facilities Management, the University of Arizona. Then I bring on Corey Metzger, PE, Founding Principal, Resource Consulting Engineers, LLC. And then I've got Victor Passeri, CEFP, Director of Facilities and Construction, Brentwood School. If you've been on any of our town halls, you have seen these folks' faces. So now I'm going to go on screen as well. And I just want to close the loop on this with my panel, because I think, Karen, you really brought it full circle, and I thought that was perfect. Chris, I think you have a pretty robust program as well, and so you might want to think about that. And David Kang, you're using technologies to incredible advantage. I heard some of what you were doing. Are you aligning those technologies and access with some of this kind of testing, tracing, or some other angle? So I'll go with David Kang, and then I'll come back to you, Chris.
Well, you know, the idea of taking the questionnaire and then controlling access to the building, that's something I'm going to definitely take back. We're not that sophisticated. So yeah, we are trying to do as much as we can, but every time I come to one of these, I learn more.
Yeah, and David, I'll tell you that I read some people are tying it to the IT access and address, and so it gets cut off unless they come do what they're supposed to do, or they respond to the contact tracer, which is amazing. And then obviously to building access, but to, he said, just to dining, and generally speaking, you can't get in. Chris, did you want to add anything to that?
Well, it's similar. We're finalizing our plans for our reentry, and as I've shared in the past, not only during my day job, I'm also have taken over our incident command as the commander. And so as we have a number of task force that have been put together, we've had a great group that have been working on spring reentry. Spring reentry for us is on the 13th of January, and we're going to be doing testing starting on the 4th of January. But also, it's not just now our students in the dorms as we did in the fall. It's every student who will be on campus. And so if you're taking a class on campus, if you're living in an apartment, if you're coming from home, you'll be required to get testing. And if you don't, then the IT, as you mentioned, Lander, will be cut off. You will not be able to use that. And so that's really critical.
Okay, so you are going to do that. All right, very good. So as I mentioned, the survey results, we had close to 300 institutions respond. It was really quite robust. And on this particular question, we had some challenges that were identified, and in particular costs. And I know everybody on this call knows, he just called it the black COVID hole, for heaven's sakes. Timeliness, it sounds like because they have the internal system, they're able to manage that. They had testing capacity, just burnout from, and then he talked about student compliance, and you see the protocols they put in place and what some of you are also doing. And then the COVID spread is going to really make this very difficult, and it is quite unpredictable. So those are some of the things that we have found. So let's now, and you can see right there on the screen, and by the way, every one of these slides will be available, whether we either do or don't get to, be totally fine. And then also we do have all of the survey results in summary, detail, the infographic, et cetera, already posted on the APA COVID-19 resources website. So they're there. And I'm telling you, people responded. There's so much robust and great information in the long form responses I was just really, really impressed. Any of you, and maybe you can give me a sense of the impact of personal behaviors on protocols. Any of you want to tie into that? Karen, you were asking that question. Maybe I'll use you to bridge from that question, and then we'll go to the next topic of HVAC.
Yeah, so most of our students are doing the right thing, and our faculty and staff as well. But you are having these that we either don't know what they're doing or they aren't behaving. So those are challenges that we're trying to work on. We do have a student expectations document, very different from anything that we've ever done before, that is the same for every one of the 64 SUNY campuses, saying that this is what we expect of you and how you're to behave and how you're to, wear masks and do all of the things that are the right thing to do in this particular situation.
Okay, very good. And by a show of hands, how many of you did exit testing before you sent them home? Any of you do exit testing? Okay, so we have most people on this call were doing exit testing because somebody had asked that in our Q&A side. And then does anybody have a remote satellite campus? I'm interested to know because someone was asking what some of the challenges might be for a remote. Anybody with a remote satellite? We just heard from Duke. They had one in China, my word, they were on top of this.
I can jump in there. I can jump in there. What we did on our campus as a whole, we broke the entire state of Arizona into 12 zones. And so as we looked at initially 10 zones within our main campus, also including our medical center, we then had project managers assigned to those zones to go ahead and address all the unique needs. We then looked at the city of Tucson, where we had leased property, we had any other university property. We have a number of telescopes throughout Arizona. We had to reach out to those, and then the entire state of Arizona, we signed a project manager. So not only from Tucson, we went all the way up to Phoenix, Maricopa, to Yuma, to our extensions, to make sure that we were covering everything. And then on a weekly basis, starting in June, we met with those key contacts, the building managers, initially to address the fear and trepidation, but then really using that as a communication piece to let them know this is what we're doing to bring campuses back up and running, doing it in a safe manner. And as we said, do we want to continue those? By a show of 100%, everybody's like, this is some of the best information they get in terms of keeping their colleges and departments safe. And so we're planning on doing those all through 2021, similar to what APA's been doing here.
Okay, very good. That's excellent. And Karen, I'm going to close this one out with a question that came regarding some specific communiques or an article about SUNY. And regarding the exit test, it said that if they tested positive, they couldn't leave campus and then go home. Was that the case? You're nodding yes. Yeah.
Yes,
Yeah.
that's what we created, because the whole idea of the exit testing is to make sure that we weren't going to take the students and then spread that to the community. So we put a lot of effort into making sure that we were going to take care of those students. We had over 200-ish students that ended up on our campuses throughout the Thanksgiving holiday.
Well, there you go. So they put an enforcement teeth into the threat. And yes, Ted, that was a big inconvenience for all concerned, but you also may have saved lives in terms of the students' families. So I give SUNY real credit for that. All right, I'm going to move to HVAC retrofits and upgrades. Boy, we had a lot of stuff going on, and I have pages of long form responses from the survey, and I want to take a look at those top challenges real quick and then ask a couple of our folks. I mean, those challenges indeed were costs. I mean, for heaven's sakes, just the labor to do the supply chain has been a big issue. I mentioned that earlier in the infographic. MERV filters, being able to get the supplies has been problematic. And then I really like this fourth one of managing perceptions of the community. And I would love for David or Corey to maybe chime in on that, because that really was a big issue because the more we got information from CDC about close contact and about aerosolized particles, it was very important that we communicate. So maybe the two of you could pop in on that. And then Another was this bringing in outside and fresh air. Someone commented, it was a very good, they said, buildings without mechanical ventilation remain a challenge, and we will adjust occupancy and add portable filtration as necessary. Corey, I'd like you to address that when we come off of Dave talking about this managing perceptions and the communication. And then Victor, I'd like you to chime in at the end of that. So David?
It's not just us, but it's also the community. We forget to talk to each other sometimes. And especially within this pandemic environment where the state and the county are making decisions, it's really important for us to be connected, for them to understand what we're doing, why we're doing it, and what those impacts are. So, I mentioned before the close interaction that we had with our faculty members that are experts in whether it's epidemiology or chemistry or aerosols, who are nationally and internationally known. So working really closely with them, hosting town halls, meetings. We actually did joint meetings with the city, the county, as well as CU to answer questions, to issue procedures and protocols and policies. And we met daily with them as part of our emergency operations center to make sure that we were well coordinated. That didn't happen initially, and so we quickly realized that that was extremely important. And then, bridging that to, the school district and other entities within the city of Boulder, the county, and the state at large, I think created confidence that the university really was doing everything it possibly could, everything we possibly could to create a safe environment for return to work. And so many of you probably experienced similar things at the onset of the pandemic. Everybody was worried about air and social distancing and how we're going to do that. And as many folks have realized, we have had no verified transmission of COVID within the spaces that we are managing. It's always been external. It's been dining. It's been the parties. It's been things that we haven't been able to control. And the community realizing that has created a lot of confidence in the university and our ability to maintain a safe environment. So that's been extremely important.
That's really good to hear, David. And, there's this saying about Boulder, it's 25 miles of nirvana surrounded by reality. Did I get that right?
Yeah, we live in the Boulder bubble.
The Boulder bubble, right. I'm not sure that we have a complete bubble, but we are trying to get there from here. And so that is really good. That transparency builds trust, confidence in everyone. And it's really, really, and I hope we're going to continue to do this in the future and not go back to old ways. David Hamwork, I want to, can you respond a little bit differently? And maybe this is about, there was a statement made, every institution now wishes they had invested years ago in continuous commissioning. What do you think about that statement? Is that, would that have really helped us? Talk to me about that. Can you?
Yeah, I think in some respects it would, but most continuous commissioning is going to deal with, maybe hot, cold calls and other environmental controls and predicting problems in your HVAC systems, particularly in the case of, COVID response. It would tell us if we're ventilating properly and give us some information back. But I would argue that I don't believe until just in the recent years did we have the technology and the software and the business intelligence to really start elevating our continuous commissioning to where it can be automated. But, it's going to accelerate now because of this crisis. So I think that will help. And I think that'll be part of the ways that we can communicate what we're doing inside the buildings to be proactive that addresses this public perception. What are you doing to make my air safe? I think that's always going to be a challenge because people can't see what's going on in the mechanical room that's making their air safe and clean. But if you have elements inside the space where it's like in doctors' offices, you see these UV lights that are washing the top of the ceiling and the upper air. A lot of people see that and they have a higher confidence. That may or may not actually be bringing the higher level of safety to the space. But perception usually is something that provides an opportunity for people to feel comfortable, safe, and perception is reality for a lot of people. Very good. It is, and that's very true. Corey Metzger, I'm going to you about that other
comment that was made, buildings without mechanical ventilation remain a challenge, and we will adjust occupancy and add portable filtration as necessary. I know you are an ace in this from your ASHRAE work and also in your consult practice. Can you talk a little bit about that, or even in this bringing outside air and implementing dedensification?
Sure. So in the guidance documents that ASHRAE has released, we certainly are still recommending targeting either meeting ASHRAE standard 62.1 for ventilation rates or the respective local code. That being said, we fully understand that there are a lot of buildings that are occupied that don't have mechanical ventilation. And we have also shifted from an initial quick response of we need to ventilate more all the time to we really need to provide clean air to spaces in response to the virus. So that clean air can certainly be, at least from the perspective of the virus, can be provided through filtration and through local air cleaning devices. So it could be in room, could be permanently mounted in the ceiling, could be central equipment. But there's certainly an opportunity to address that. Now, the thing that doesn't do is address indoor air quality issues in general, potentially long-term. So that's a good short-term solution. Probably, as David said, this has highlighted a lot of things for us and may give us an opportunity to recognize indoor air quality from a more fundamental level moving forward.
That's a great point, and I think it may be part of what we build as our business case to get there from here. Victor, can you talk to me a little bit about this, a very different environment, and you've been doing some really interesting things in this regard. Maybe you could speak to some of those things that you've been doing.
I'd love to, but I want to answer managing perceptions of the community, because I think that's very important. For us, K through 12s, it's important to have faculty and staff feeling comfortable with students returning to campus and that they're going to be safe. And also being in LA County, we get a lot of information about what the county's doing, standards that they're putting in place, places closing, opening, reclosing, or reopening. The first, we were allowed to reopen in October at 10%. That was up to 25%. So there's just a lot of information out there. And then depending on where you get your information for our faculty, staff, our parents, you're either getting stuff that's based in science and engineering, or you're getting opinions. And for us to be able to have teachers return, we needed to spend time talking to them and educating them on what we're doing and what's the science behind it. Our faculty got to hear about ASHRAE. They got to hear about MERV 13s and 14s, advanced HEPA systems, air exchanges, filtration, and that size of the virus, what's a micron versus 2 to 3, aerosol versus droplets, dry droplets. And it sounds like a lot, but it was very important for them to understand that we are looking at science versus just leaving a window open and hoping that that open window is going to have a positive effect on anything that's in the room. And by doing that, we did it in two ways. We did it once with a faculty and staff meeting. We also had the nurses talking about county requirements, but the bulk of it was facilities talking about all the adjustments that we've made to the spaces to be able to mitigate the virus. You can feel that there was a relief. You can feel like weight was taken off people's shoulders. There were lots of thank yous and lots of letters of appreciation. The chat box blew up during that meeting, and it did the same with the parents. Going forward, where we knew before we walked into it, based on surveys, that we were going to have a limited amount of faculty that wanted to return, and we needed a certain amount of faculty to be able to hold indoor in classes. Those numbers went up. We did a survey afterwards, and we have more people committing to it. So I think there's a lot of value and importance to that, and I think we're going to continue to do it, especially when there's quite a bit of misinformation out there. It's important to educate the educators so that they feel comfortable with what we're doing. And then the second thing I think we've been very fortunate doing is working for a private institution. We have the abilities to do things a little bit different than other K-12s have the opportunity to do. So we followed the studies that Columbia University was doing on the benefits of UVC. We also studied what New York City MTA was doing on sterilizing their buses and sterilizing their trains. And so the success there. We were able to get by the same systems that the MTA was buying early before information came out from the FDA, CDC, and other manufacturers started with UVC. We started studying and understanding that it's not just the light, it's the intensity and the time of exposure that makes a difference. We've explained that our faculty, we put that in place. We were able to buy early electrostatic sprayers and started using that and explaining that, the benefits of that, and then putting together a comprehensive program where we have detailed list of what we're doing per room as the room's being occupied, and then we have somebody coming to check it, because we're concerned that if we send someone in and they're disinfecting and then the final process is putting UVC in, but they forget to dump the garbage the next day, what is the perception going to be of the faculty member? They're forgetting the garbage. Are they disinfecting? Are they hitting high touch areas? Are they doing UVC disinfecting as they're saying? So another element which was really important is to make sure everything's being double checked. We worked really hard on gaining credibility, and all it would take is 1 or 2 people not following what they needed to do to lose all that. So fortunately, we've had the resources and also the support of the administration to do it. And now, just because, again, our outreach and our information we've been providing, we have the confidence of the faculty and the parents.
That's really great. And someone asked on the chat, Victor, if you would be willing to share a recording of the meetings with parents and faculty, or is there a general outline of the topics that you covered? Maybe we can do that for Sharmila, I think is who asked us. Would that be possible?
That's possible. I can definitely provide the presentation.
Perfect.
There may be some information that I might be taking off of it. That's just for our community. But the bulk of it is fine. We can share that.
That would be terrific, Victor. And, you know, we really appreciate it. And I know folks would like that. And someone had asked about installing UVC in the ducted airstream campus wide. Is there an effort to do that? Maybe I could get both David Hamwork and Corey. You guys want to pop on that?
I can start on that and Corey can follow up. I'm a big fan of UVC as being an effective measure. One thing that has to be very clear that you have to have a UVC system that's designed properly for your air handler. And it is, once you start doing it campus wide, it starts getting into a very high capital cost. So you got to make sure that you don't just get something off the shelf and you just add it to your air handler, because UVC light is very effective when you have the intensity of the light, proximity, and time. You got to have those 3 elements for it to be very effective with pathogens.
Very good. Corey, do you want to add to that? And then I'm going to go to wastewater.
Yeah, just briefly, I think the key thing to keep in mind with UVC is whether or not you're implementing it for keeping coils clean and having the added benefit of some disabling of viruses or killing a bacteria, or if your goal is to fully disable all the virus in the airstream and kill all the bacteria, because they're significantly different intensities that we're talking about at those cases. So can be benefits to both, but it needs to be considered carefully how it's implemented per what David said. Thanks.
Okay, that's excellent. Thanks so much. So I'm on wastewater testing. And there were some top challenges that we found in this regard. And one was, wow, it's expensive. And Chris, you know that. You've been in the middle of that. Karen, you know that. You've been in the middle of it. So a number of you know about the cost and the expense. There were some interesting challenges that people came up with when they were writing in their long form responses. And you can see some of them that we captured in terms of not being specific about a location because the sample was pulled from manholes that maybe had more than one building, and that could be complicated. So maybe you could think about that and respond to that. Was there additional staffing that was required? It said they did have extraction locations were really interesting in terms of being on major roadways and the timing of doing that. And then they put the nature of work itself. All right, come on. You know, waste is waste. What can I say? So maybe, Chris, you could chime in on some of this about these noted challenges. And maybe there's some of the ways that you have chosen to mitigate them. And there was one comment before you where you speak to this, it said high failure rates due to continued presence of viral load in wastewater after first detection creates false positives. I didn't understand that, and so maybe you can consider that in your comments. And Karen, I think that you probably have had some experience here too. Chris?
I'll right before I jump into that, I will say on the last question about the HVAC system and the filters, at the University of Arizona, we're doing a test pilot right now because the supply chain issue that was mentioned with the MERV 13s, we're all trying to pull from the same supply. We've sent out some filters out to UK that they can coat it with a zinc substance, and the Navy SEALs use that substance on their outfits when they're in some pretty bad water. We're testing that right now in our isolation dorms. We'll keep you posted, and if that's successful, we won't have to go ahead and use the MERV 13 filters. We'll be able to just coat the 7 and 8s, and we can talk maybe at a future date on those.
Fantastic, thank you.
In terms of our wastewater testing, we're real proud. Ian Pepper, one of a world-renowned researcher, I've really got to know him well, and that really speaks to the silos that have been really eliminated, the partnerships that have taken place between our facilities leaders, our medical researchers, our other type of researchers. And Ian, he has been testing the wastewater for a period of time in our county, and it has been detected. And the question you raised about false positives, we've looked into that. Matter of fact, we looked into that way up front. And so when we brought our students back on campus, they were all tested. We only had 5 who went into our isolation dorms. But that first weekend, on a Sunday night at 11:45 p.m., it was all hands on deck from our incident command team, because Ian's test now of our dorms has just shown a number of positive cases. And so now we're saying, all right, what do we do with that piece of the puzzle? That piece of the puzzle, along with our public health professionals, along with our researchers and our antibody and antigen testing. And so we then went ahead and reconvened that whole testing of 300 plus students in that dorm the next day. We found 2 who were positive and put them into isolation. And so we have expanded our wastewater testing. Yes, it's expensive. It's gone from roughly about $500,000 to over $1.2 million. However, the safety of our faculty, staff, and students are critical. So we expanded it from 12 dorms to every dorm we have on campus, which is 24. We expanded it, which initially was none of our Greek life. 23 buildings were in it. Those are all private entities. We went ahead and expanded it to our entire Greek life system and these large sky-rise apartments around the perimeter of campus. And the issue of getting access into the manhole, well, that's that collaborative partnership we've been able to take advantage of that we built over the years with our Pima County sewer folks, where we meet on a quarterly basis in terms of infrastructure, planning ahead, what challenges, capital projects. And then as we continue the testing, the positive, false positive, we use that as one of the measurements to say, all right, it's not going to dictate exactly when we're going to be going and testing all the buildings, but it's a piece of it. And so the testing that we have going on with our antigen testing, the PCR testing, campus health, we've set up 5 locations on campus within our rec centers, our student union ballroom to do daily testing. We use that as a piece to measuring, and then we go ahead and just make sure we have all 3 pieces working basically in one song sheet, using the metrics to make good solid decisions on what we should be testing and spending, allocating dollars on.
That's perfect. Karen, do you want to chime in?
Yeah, so it's interesting because what we have actually done is primarily abandoned our wastewater testing. And that is because of the false positives that are the result of individuals who then come back to the campus proper after they've isolated, and they continue to shed the virus long after they have completed the point where they're actually able to contaminate other people, right? So because of that, it just became too difficult. It was sort of good for those initial outbreaks to recognize, oh, we've got one that's starting. But at this point, instead, where we're really having a lot of our discussion is related to staying with the pooled testing, which is what we've been doing, 12 students in a pool or faculty staff also, or moving more to the antigen testing. And the difference being the pool testing is more accurate, but because it's PCR testing, but it does take 24 to 48 hours to get the results. The antigen testing is, 15-minute results. And the antigen testing is also much less expensive. So we could do more frequent antigen testing, and except that there's this false positive problem that they believe exists with the antigen testing. However, one of my campuses, Binghamton University, used antigen testing throughout the entire spring or fall semester, whatever we just finished, and did not have a large number of these false positives. So it's a debate right now. We're trying to figure it out. Those $5 tests that are out there now from Abbott, and there's another manufacturer with a $10 antigen test. The Abbott test, they're also looking at the ability for the data from the tests to then be fed right into your campus data system that's collecting your testing data, which would be a really nice additional benefit, because that's one of the challenges as well, especially with 64 campuses, collecting data from all of them to have and report out publicly. So that's where we are with wastewater, pretty much not using it, but trying to think about the antigen testing.
Got it. Okay, that's really excellent. So I'm going to do a couple things here. One is I'm going to highlight what Victor mentioned, is it was highlighted in chat about the validation of the work performed to prove to building occupants that the cleaning regimen is complete. The comment is such that it's saying, let's make sure that we continue. It isn't cheap to do it, but it's really important. And I'm hoping that this validates that we should continue this after COVID. And so that's really important, Victor. And I think that folks are identifying with that. And then I have an interesting one back on the UVC, and then I'm going to go to you, Nell, because I'm going to get into that whole area of pandemic fatigue and the exhaustion. All right, so get ready to be teed up here. Okay, so someone asked about, please clarify your focus on UVC effectiveness. Disinfecting a surface in an AHU is significantly different than disinfecting and moving airstream. Additionally, there are considerations of material degradation under UVC light. Is this a Corey question? I'm going to ask Corey, is that you? Is this Victor? Is this David Hamworth? Anyway.
I can start, and then certainly Victor or David want to chime in. That's great. There's no question that the application of UVC or UV germicidal irradiation in general needs to be carefully considered to make sure that materials are compatible with the application of lamps. If they're put in the wrong area, they can quickly lead to degradation of certain types of materials. There was, I think the beginning of the question was about the intensity. So it really comes down to how many how many microwatts we need to apply to an airstream or to a surface. Achieving surface cleaning requires a significantly lower intensity than trying to clean an airstream, if you will. Okay. So I guess that would be the key takeaway. I don't know if that fully answers the question. Certainly, Victor or David, if you've got thoughts, that'd be great.
Okay, that's good. That's good.
Hi, I can jump in.
Yeah, go ahead, Victor.
So we looked at the use of UVC through our air systems and quickly realized that the cost modifications that we need to do and what the benefit may be was just not worth it. Between bringing in a certain percentage of fresh air, filtration, and exchanging the air in the room, we didn't see any benefit in it. But when it comes to our classrooms, we do it as a sort of a 1-2 punch. It's part of a system of cleaning. We don't totally rely on UVC. We probably use more of it in our lower school because children and disinfectants don't mix very well. So we try to use cleaning materials that are designed to be used in daycare facilities and in elementary schools, but rely more on the lighting there. But with our middle and our upper school, it's disinfecting. We're spraying something that's light. We're making sure we're hitting all the high touch surfaces. And then from there, we're setting lights. And the way we set them is on two sides of the room. So the light's coming from two different directions. The problem with setting it in one direction is whatever's in its way is going to cast a shadow. And then whatever area falls in that shadow, the light's not going to hit and disinfect. By doing it from opposite ends of the rooms, you lessen that. And you're also hitting areas you wouldn't normally disinfect. Carpeting, the ceiling, the walls, spots that you would just keep off. There's some benefit to it. The important thing is that we had to create also knowing the intensity of light, and we use a pulse light, we had to understand exactly what the time is based on the size of the room and the distance of the lights to the fixtures, and then create a system that we program timers that we gave to our custodial staff that was set for each room so that they gave it the proper amount of time. Too much light is not good. Not enough light is ineffective. When you put those protocols in place and make sure that we're constantly training and retraining, because it's easy to get comfortable with it, to have somebody say, oh, I don't need to do it that long, or I'm running out of time, I'll put it 5 minutes here and skip the other room. It doesn't work. So that we had to make sure that was as foolproof as possible to make it effective. But I wouldn't solely rely on it. It should be part of a comprehensive plan versus just a standalone way of dealing with the virus.
Okay, very good. All right, I'm going to pop on to you now. You're up. And this has to do with the question around pandemic fatigue, and you can see this picture. Oh, my word. And you can see all the reasons. Look at all the stuff you're in the middle of, for heaven's sakes. I mean, this is insanity, right? I've got 8 people, trying desperately to do all the great stuff here to chime in and to help. And we've got Nell, who's going to talk to us about this pandemic fatigue affecting you and your staff. And you can see from the survey responses that it's affecting morale. It's driving this whole attitude I spoke about earlier of complacency. I just don't want to do this anymore. This idea of, yes, mental health issues, we have real absenteeism as a result. I mean, you can see the list. And now I think that's a concern for everyone here. And I had probably the most responses from the survey asking like a ton of questions about this. And they said it's an ongoing challenge. This is one where we continue to discuss initiatives to support staff and students. And it says after 9 months, it is definitely affecting us in a mental way. Now, can you talk to us about some ways that we might consider the staff mental health and ways that we might address it and support them?
So sure, thanks, Lander. I would add one other thing to that current list, and it's being experienced by hospitals a lot, but I also think by campuses, which is with the sheer numbers of coronavirus cases now, the number of actual employees that are either ill with COVID and out because of that, or out because of quarantine has, of course, become much larger and much more significant to operations and to the continuing functioning of operations. So you add to that the fatigue, and I would add it's not just fatigue, it's a kind of sluggish thinking that people don't keep on top of things as well. So it's clear that we've done an enormous amount in the first 9 months. But if you watch some of the projections for the future, it's not a quick change over to vaccination and then we're out of this. We're really got a lot of time to go. So I return to the basics because both they're the easiest available and they're the most successful, and anything else you put on top of them don't work when you don't have them. So what are the 3 basic things? Are sleep, nutrition, and exercise. And I've been thinking about exercise a lot because it's for both students and I also think for staff. When you get terribly busy, it's the way you generate time is to give up those kinds of activities. And I realize also on our campuses that we've systematically taken a lot of the exercise spaces and made them testing facilities, so made them unavailable. I would tend to suggest to people that they ought to think about retaking some of those spaces. And now that you have proved to be so good about carefully managing indoor spaces, and behavior in those indoor spaces. I know that there are some gyms that are certainly not doing anything in our modes of transmission. There are ones that are extremely careful, scheduling times, requiring masking, having appropriate spacing, looking at the ventilation and cleaning, that are excellent sources. And I think all of us having to sit on Zoom meetings all the time, it's amazing how much strength, how much physical strength we've lost. And so for my biggest plug is putting into exercise at this moment. And for many people, that's going to be different kinds of things. So it's not going to be enough to just say that you should exercise. It's probably going to be giving people time during the day to exercise, figuring out what impediments there are to doing that. People may need individual instruction about what that might involve for them and for their families. But I think it's the cheapest, quickest way to get better. And people often think, this is always true for many chronic medical problems, back pain is the one that was probably most studied, that when you suddenly get a vacation or you get back pain, you should just rest and continue to rest. And we know quite clearly with back pain that that does not work. And Lander's shaking her head. Right. It's with all of this as well. So I think in the downtime that we have, we're really going to have to focus on exercise somewhat in the community way. Again, because this is applicable to the broad swath of people. It helps people sleep better. I didn't give you the reference last time about sleep, which I love, is Matthew Walker, currently from Berkeley, who wrote a book called Why We Sleep. You don't have to read the book. Go on YouTube and just put Matthew Walker sleep, and you might get a 20-minute YouTube clip that you might want to show your staff about sleep. Because what happens when people don't sleep well, they, number one, can't perform well in the daytime. That data is extremely clear. But they also begin to do things like drink to go to sleep. And that starts a negative spiral, which again is going to take us down a hole we don't want to go down. And then I would also say that we can do a lot with nutrition, and that's an enormous piece of this. The other thing I think, as several of you mentioned, I think one of the huge benefits that has come out of this is the number of people on campuses who are working together effectively, who used to not work together very much. So I think link arms, because then when one of your colleagues sinks quite quickly, we will realize it and we will be there and have their arm to make sure they don't sink into that hole. The bad news is, that's important for us because people look to us and borrow our mental health when they need it. And we walk them through this, right? So we have to take care of ourselves because we become the people that are crucial to the people that are working for us. And I can't emphasize enough that that is important. And I would also say that as things going into January, February, the new year, many things will change. I think we'll find supply chains will be some different. I think national strategies will be different than what we had before. And we're going to have to remain flexible in our thinking and our approach. And in order to do those things, to remain flexible in our thinking, we need to sleep and we need to exercise. Honestly, it's like the golden rule is you got to do that stuff. So if you want people on your campus, I was thinking this too, Lander, one of the things that got me in contact with all of the kinds of people in your organization who do so much for the campus, one of my colleagues just said, I'd love you to come and talk to my staff. And I didn't know what she had in mind, but I said, sure. And then I began the steps. I sent you that Harvard Crimson article about where the students had gone into figuring out all the holes and all the staff we forgot to add into the testing and all the people who felt left out of the things we were doing for students but weren't doing for staff. And I thought, we've got to think about those things. These relationships matter. Helping each other out matters enormously.
That's excellent, Nell. It's so true. And I am not getting points on any of those. So it's just a sad state of affairs. And I'm not even going to ask the rest of the team to raise their hands if they're getting any sleep, exercise, and nutrition, but I am renewed. And I am excited, and my husband is sitting near me, and he's going to say, I am witnessing you are going to do something different about this. And David King, I did want you to focus, there's a last bullet there, fairness issues between remote staff and essential workers, and we have just enough time. I think that you have been really into these kinds of things and the things that you're trying to do to reward and recognize, but there are differences. And you know what I heard is well, the remote staff get to work at home. Okay, now listen to my language. And the essential workers have to come to the campus, and everybody is needed, and it's really hard to demonstrate that. So could you talk to us a little bit about maybe what you're doing in this regard, because I think you've been on top of this in very interesting ways.
You know, I think just as part of being leaders, it's recognizing that, you know, we have different folks that do different things, but that we all contribute to the mission, right? And so there are different ways that we do that. But I think a critical piece of that is recognizing that they are important, making them feel like what they do is important in different ways. You know, as an example, you know, I was so fortunate that one of our employees got selected yesterday to be Employee of the Year for the campus. He's the Director of Transportation Services and Distribution. And when he went up to get the award virtually, you know, he recognized the folks that never hear a thank you, right? The folks that are driving the buses or distributing the mail or changing the system so that the 500 labs that we get are getting the supplies that they need. I remember vividly having a meeting with the Dean of Engineering, and he says, Dave, thank you so much for all the work that your folks are doing, because sitting behind me are 2 pallets of cleaning supplies for my labs. So these are the things that our folks do every single day, and it's so important for them to realize that the university would not be able to do what we're doing without them. And that's saying that every day. That's encouraging the provost and the chief operating officer and the chancellor to mention those things. I got an email from Chris Ewing, my AVC for Planning, Design, and Construction. In one of our town hall meetings, the provost made a closing statement about what a great job the facilities team did in preparing for the campus. And he said the text messages were exploding from people within our staff, from his staff, that heard that. And so I think it's so important to recognize that and then bring that visibility to the folks that are actually doing that day in and day out, whether they're doing it from home or doing it in person. Everyone has a role to play, and we need to recognize that.
Wonderful. And I want to thank all of our panel for stepping up, being available, doing this, being the experts that they are, and recognizing that we are all in this together. We won't go through the rest of our slides. The surveys are there. We've just had a great conversation, and that's what this was all about. It's so important. There are other slides about our upcoming APA Facility Symposium in January, and FPI survey tools now open and live. We have an app. We have COVID images where the save the data is there, but I would say it may not have felt this way many times throughout this past year, but we have much to be grateful, and this year has thrown every challenge imaginable at us. But seeing how resilient people have been and the creative links they have gone to in order to find joy has been inspiring. And I want you to ask, just sit back for a second. You know, Nell just told us to relax. Okay, sit back for a second. I just want you to take the next few minutes. The staff have put together an amazing special video clip of the year in review, and I would like us to just look at that.